Right, so who'd like to kick us off?
Thank you. It's Matthew Claxon, Moore Blatch. I have a question in terms of the venue for the assessment of a claimant. Would you, and perhaps this question is directed to Dr. Munglani, would you prefer to see a claimant in your clinic or in their home environment where they are, I suppose, exposed to the issues which perhaps influence their behaviour?
That is a very good question. I mean, for the big spinal cord injury patient cases I see, I go all around the country, and of course you see them in the home environment because they simply can't get to you. It's very interesting to see. I saw some cases. That there was that I was call it Fairground, right? I don't mean that. It was that big dipper that crashed and people got legged out. And I saw one or two of those sort of patients. But there was the front row that got really badly damaged, and then one or two other rows were. And it was really interesting to go and see one of those patients in the home environment who had developed a chronic widespread pain picture, and you could get the sense of what was going on. And it was much, much better because they're much more relaxed, they're much more themselves, they're not preparing for an interview. Because what you really want to know is, what are you really like? Rather than thinking they have to prove something to me. I'm sorry I didn't have time to go through all my slides. One of the things I was going to talk about, the Waddell signs, is the discrepant signs. And one of the things you see is that we see it a lot. Does it mean they're all malignant? No, because often it's a desire to convince rather than a desire to deceive. Because they're very stressed, they want to tell you how bad it is. On a bad day, they're awful. And when you see them in the home environment, that stress levels are usually much lower. The only person who stresses is me, because I spent bloody 5 hours getting there along the M6, and that's a different matter. So it's if it were, and obviously there's money and time involved, so it's not practical apart from the very big cases, but it is a very good point, and I would agree with that.
Hi, this one is a question for Dr. Master. My name's Amy. I can see on your list of treatments you've not actually mentioned meditation. I've recently been reading a book called Siddhartha's Brain, which talks about Herbert Benson, the kind of first cardiologist who cured the kind of psychomatic relationship between the brain and how to lower your heart rate. Is meditation something that you promote and is that becoming more common in terms of a cure?
Thank you very much for that. It was an omission. It's an important aspect of treatment, and the mindfulness is a very powerful tool, I find. It's something that can be easily delivered. Patients don't need to go on courses because there's such a super app, which I'm sure lots of you will know about, called Headspace.
Yeah.
I mean, for those of you who don't know Headspace, I thoroughly recommend you have a look at it. It's tremendous, and it's a kind of standard recommendation that I make for all my patients and for myself, incidentally, as well. It's after doing it for a while, it can be used as a form of kind of SOS anxiolytic as well. With practice, and a lot of patients can pick this up very, very quickly when they get hyper-aroused or hypervigilant or whatever. There are very easy and easily applied SOS techniques, some of them to do with breathing. One that I often recommend is so-called 7-11 breathing, which is easily done, very effective, quick onset. If you want to hear more about it, ask me later and I'll give you a demonstration.
Andrew Willie, Farrar's building. Easy question is, what is fibromyalgia?
That's easy, is it? Okay. I didn't go through the mechanisms of the various pain states. But I did sort of allude a little bit to the development of chronic widespread pain and the epidemiology in the community. Like I said, Manchester was 5%. And what do we mean by fibromyalgia? Well, fibromyalgia was a very strict diagnosis many years ago by the ARC, the American Rheumatology College, and by a chap named Wolf. And it basically said you had pain in 4 quadrants of your body, so you couldn't just have fibromyalgia half body, that because that would be like a stroke, and there would be other factors like fatigue and other things coming in. You'd have tender spots of 11 out of 18 tender points. That's okay, but it told you nothing about the mechanism. It just said, well, you've got tender spots and they're all over your body. I mean, what does that mean? And what is clear now is that we have in our brains, particularly in our hypothalamus, a gating mechanism. And Dinshaw actually referred to it in a very useful way. He said, actually, most of you are not aware of sitting on your bottom until I immediately mention that word. And immediately they, oh, yes, it's really quite uncomfortable seat or something. You got that. So we basically filter the information. All of it gets in. I wouldn't have used the word white noise because actually it sounds like it's all garbage. It isn't. It's all going in all the time, but it's not attended to. It's not focused upon because it's not actually useful. What happens in fibromyalgia is that selective filter goes the other way and it amplifies right up. So everything gets felt. So the odd sensations you have in your body then get amplified up, and as we call it being attended to. Now the interesting thing is, so you look at that mechanism in, I'm going to go on a tangent, like post-traumatic stress, where they become hyper-vigilant about everything. They often get very similar type symptoms. Now, in fibromyalgia, there are co-localizing diseases. One is irritable bowel, one is irritable bladder, and the other is migraines. All of them are the same. You know how when particularly if you had a curry like me the night before, it's a bit gurgly, your stomach, and it's a bit, maybe, okay, it wasn't the curry, it was the 5 pints of lager. and you know what I mean? And you've got those funny aches and stuff. And so, but if you have fibromyalgia, that won't just be a little ache and a bit of, a bit of dodgy tummy. It'll actually feel incredibly painful. If you've got interstitial bladder problems and things like that, the bladder becomes very painful. Your headaches are not just a little bit intrusive, they're terribly intrusive. So again, you attend to all these other symptoms, things that you would have kept under control. So what you find is that the system is over-amplifying. Now you think, what's the basis of that? Well, firstly, you can show it is over-amplifying because you can see it on functional MRI scans, and I won't go into the details, but basically things get magnified up. So a little ping prick, which will light up one spot in the brain in you or I, in a fibromyalgia place, it will give a whacking great signal. Okay, it will light up everything. You can show that after certain whiplash injuries, that's very common. That central sensitization, that amplification does occur, but it usually gets better. Some people it doesn't. And the second thing you can show is that sort of amplification is the basis of fibromyalgia, and it is associated with a deficiency in chemicals in the brain. And this is very simplistic way of putting it. And the two chemicals that become deficient as your amplification system has gone right up are noradrenaline and 5-HT. Those are the two basic ones. There are a few others. If you look at what antidepressants increase the levels of, are exactly those two chemicals, noradrenaline and 5-HT. They up them again, and so that is why fibromyalgia patients are often treated with antidepressants, because it helps to turn that volume control right down. Is that the only way you can do it? No, you can actually use other techniques. You can use meditation, you can use CBT, because you can show that on functional MRI scans, and even lots of them also turn the volume control right down. So basically, think of fibromyalgia and think of chronic widespread pain as that the amplification, that your selective filter has gone the other way and become an amplifying system for lots of different reasons. And what you're trying to then do is turn it right back down again. So simply by doing those sort of treatments, the widespread florid pain and other symptoms you feel, including fatigue and other things, start to contract again and start to come under better control. Does that help? Does that make it? Yeah. Okay, and so chronic widespread pain is for people who do not fulfill the criteria of the very strict criteria for fibromyalgia. I was saying to Dinshaw earlier, in Europe we tend to use CWP. It's a much more widespread, much more prevalent condition because it's present in the general population, and about only 20% of the people who have of chronic widespread pain have fibromyalgia. So fibromyalgia is like a tighter, higher barrier to cross and reach. Chronic widespread pain is an easier definition because it's much easier to define. And then, of course, you go into causation. Would it have happened anyway, like I showed on some of the slides, if you're a vulnerable individual, or would it happen? And, of course, when you have bad things happen to you in your life, it doesn't have to be just physical. It can be mental issues. You can get chronic widespread pain. So we know this system of being filtered, becoming amplified, can happen with lots of different conditions. It doesn't have to be just trauma. can just be general life, having a bad... I mean, my wife always says, every time we have an argument, she gets pain between her shoulder blades. Now, I'm not saying she have lots of arguments, but do you see what I mean? She actually says, I feel it. She says, I actually get a pain when you know, and it's amazing for her. That's how her stress develops and appears. So, and it develops as a pain. I'll stop now. I think I've rambled on far too much. Thank you.
Any more questions? Gentleman on the back.
Grant Goodlad from Farrar's building. Question for Dr. Master. You said that your preference is for treatment to be carried out after the litigation process is concluded, but we want to know how likely it is that that treatment is going to be successful in whole or in part. How definitive can you be in your prognosis, and what factors affect your prognosis?
There are no concrete guidelines for prognosis. Your prognosis is developed on the basis of your overall assessment, and the likely response is gauged by factors affecting motivation. It's very difficult. You form an impression on the balance of probabilities as to whether this person is going to get better or not, and the extent to which you're going to get better or not, which is often phrased in terms of work capacity. It's a little bit crystal ballish, I have to be frank about it. And all one can do is give an honest estimate. There are no very definite guidelines regarding prognosis.
Hi there, John Meredith Hardy. Just a question about where we're going in the future with regard to pain. I think it's maybe Dr. Munglani, but it may have a psychiatric element too. Are we going to be able to carry out scans on people's brains and so on and see whether or not we can see bits lighting up, identifying whether or not there's genuine pain or not? And does this have a psychological aspect, or a psychiatric aspect? Do you think we're going to be able to see some form of input of objective analysis of individuals to identify whether they're telling the truth, whether they are really suffering pain, or whether there's something else going on there which may be motivated, for example, by litigation?
If you talk to Irene Tracy in Department of Anaesthetics and Pain Medicine at Oxford, who I know well, she will say that functional MRI can tell you whether somebody's really feeling pain or not. If you talk to a lot of other people in the field who look at these scans, what we see in functional MRI is basically a quantification of what often patients are telling us. That's the first thing. So, I talked about the pinprick giving rise to a little dot, or pinprick giving rise to a big flare. Does the functional MRI actually tell you what's happening, or is it just reflects the experience? And what we find is that people, if you look at people who believe they're in pain, regardless of whether something's happened, and you can do some quite clever experiments, who believe they're in pain, their brain changes in response to that. If you give somebody an analgesic and it's not really an analgesic, but they believe it's an analgesic, their brain responds appropriately. So firstly, what it seems to follow is what the brain is going to do. Now, is there evidence that you can use a functional MRI to say, is somebody really in pain? The answer is it's difficult because the prevalence of pain in the general population is really quite high. And I did say quite early on, for this reason, pain has often very little to do with disability. We see people with big lighting up of the brain, they have pain, but they're not disabled. But what do you count care and assistance on? It isn't actually very much on pain. It's all about how disabled they are. So one of the issues is that the factors that determine whether you go back to work, whether you have care and assistance, is actually not really relevant to the pain. Yes, pain makes a little part of it because you get a diagnosis and you get some reward for that or some compensation, but actually it doesn't tell you about the other major factors. And this is a major issue about it. If you're saying, are people making up something completely, for example, can they move an arm or are they really blind? Yes, I think functional MRI is going to have a big role there. And, but we've known that for years. We can do visual evoked potentials and check, for example, if somebody's seeing something, is this hysterical blindness or not? Is an arm likely to be paralyzed or not? Okay, there'll be a role. But because we're dealing with different factors, you're asking about is pain real or not, and I'm saying actually what is far more important is are they disabled or not, and whether what's going to happen to them in the future. And those are and pain doesn't really tell you about that. That's the way I would answer it. I don't know if you've got any views on that.
Yeah, I mean, I agree with everything that Rajesh has been saying. I can't really foresee any major technical advances that are going to forward our understanding a great deal. I think it's going to be practical assessments, much the same as we do now.
Syndrome, and what were the results?
How long have you got? The answer is yes, there've been loads of stuff.
Yeah.
Because you, sorry. Yeah, there've been lots of studies on phantom limb. I mean, because the idea of neuroplasticity in the brain, when you lose a limb, are you still experiencing it? Do the same areas light up when the person says, actually, I can feel something on my limb? The answer is yes, it does. All of that's been done. That's how some of the validation work was done in that field. And you can show the responses to, for example, peripheral stimulation of the stump, re-evoking some of the sensations. So there's, there are a lot of good things about functional MRI in terms of understanding neurophysiology, but we still come back to that the experience of pain is one thing, and we as pain consultants, we actually we're trying to deal with how that person functions. And just like Dinshaw said, I mean, I've had a very difficult conversation with somebody on Wednesday at St Thomas's where basically they said, he came in demanding spinal cord stimulator stuff, and I just said, you're always going to experience pain. I'm not going to be able to say that way, but I can help you function better. And by the way, that's not going to involve you having stimulation. It's going to be engaging with a therapist around you, So often we end up spending time getting patients not to focus on their pain and trying to get them to focus on life and living, really.
One more question before we go for a drink.
Oh, that sounds good. Yeah.
If there isn't one from the audience, I hope you'll forgive me for asking one, because it's something that crops up a lot in litigation. It's really one for Raj, because he said something that slightly alarmed me in the talk today. Virtually all the claimants we see have some history of medically unexplained symptoms. Some of them it's very significant, others it's only quite occasional, but there's usually some history of that. And so there is that vulnerability there. And what the defence will often say is, well, you had this history, and even if you can show that this particular accident was the trigger for your chronic widespread pain, it would have happened anyway, because at some point in your life, the ordinary vicissitudes of life would have led to the same condition. Now, one of the studies that Raj mentioned, I think you were saying, seemed to confirm that. Is that right?
Yes, it's actually quite interesting. One of the studies showed that you could predict which people were going to get chronic widespread pain following an accident by all the pre-existing factors, and we talked about anxiety, depression, and you saw that one, and you've got the reference. If you look at that study, and you look at the incidence, say, of, and particularly road traffic accidents, so I can tell you the figures in the paper. The incidence of road traffic accidents in that paper was 7% over 4 years. Okay, so you think, okay, if that particular vicissitude of life, at some point they would have got it. So 7% over 4 years. So say we're going to talk about causation at 50%. How many lots of 7% do you need to get above 50? Now this is a simple maths question, there's no trick. Can somebody just say, how many lots of 7%?
7 to 8.
Yeah, so 7 to 8. So 7% every 4 years. So if we say we've got to get above 50, that's 8 lots of 4 years, okay? That's 32 years. So they would have, if it hadn't been for this accident, the chance of them definitely having an accident at some point in the future is probably in the area of 30 years. So don't get too worried if you're a claimant lawyer about this, is what I'm saying. Because it does seem to be RTAs, and there's a lot of reasons why RTAs seem to be more likely to precipitate this, and it's due to the fact of loss of control, because something happened to you when you weren't expecting it. It's that loss of control. Because if you say about childbirth, we don't seem to see the same thing with childbirth. We do not find every woman with childbirth developing chronic widespread pain. Oh, well, maybe they do, but, But do you see what I mean? It doesn't happen in the same way, but that's a traumatic event. It can be a very traumatic event. And yet it seems to be RTAs, that loss of control, the idea of something happening totally out of the blue. Often, you see the car come towards you, the inevitability or the total shock of being hit from behind. So, but the important thing about that paper is it matters in a few cases where the risk factors were so great that you think, actually, it could have been anything. It could have been something much smaller, which is why I put that paper by Dominic, which is a very, very important paper, that if you have very, very high levels of pre-existing anxiety and very high levels of pre-existing depression and lots of comorbid conditions, including the sort of things that we find in comorbid, that coexist or co-localized fibromyalgia, like irritable bowel, irritable bladder, migraines, those sort of things, yes, the risk is probably going to be much higher. And so the case that I would say to you, it doesn't fall on, in terms of development in the future, actually it's probably best done by the case of Malvicini, which is you don't say, would they have developed it or not, but you say, actually there was a risk. And so I was involved in a very big case of a junior lawyer, who's all settled now, so I can talk about it, somebody who trained at Cambridge and then after an accident became totally wiped out. Couldn't, and it was a massive claim because she was all this massive history of going to do well. And one of the interesting thing was, one, she didn't disclose to me how the other things that were happening in her life, and then it all came out. And actually, I said, I'm not surprised. And I said, and I had already given a figure of saying there was a 35% chance of her developing chronic widespread pain absent the index event. I said it wasn't 50%, but I think you need to take it into account. And actually, because I used those figures and pointed out all the things in her history when they all came out, which didn't surprise me. And actually they settled on a basis that they discounted what she settled by 35%. You may agree or not disagree, but actually it was a much more sensible discussion amongst the two sides, who then accepted the figures I'd given them and let them tussle out between them in the final instance. So yes, it can be, you can end up with a discount for the possibility, but actually you can use that same data to say, actually, people in life have lots of risk factors. Not all of us end up like this. And this is why I pointed out very carefully the study on will this patient develop disabling low back pain? And the answer is a history of prior recurrent but not particularly intrusive low back pain is not a risk factor. And in that Dominic paper where you saw the graph inevitably rising towards people developing chronic pain, the left-hand side of the graph, of course, is you've got percentage down at 5 and 10%. Because if you've only got a little bit of risk factor, a few medically unexplained consultation with the GP, we all have that. So what I'm saying is, I wouldn't get too worried about it, Nigel.
Okay. Well, thank you very much. Shall we all go and have a drink?